So we'll start this session, and so now I think because we jumped a few talks, we'll go back to them. I think the next presentation is from my department, and we'll be talking about some basic videos, how we treat the blister aneurysms in our unit. Okay. Of course, and the person chairing this session is no other than Dr. Uday Limay. So let me tell you, when I was in AIMS and our department wasn't so active, and Uday was leading the KM. They are three terrific guys. So he inspired a whole lot of neurointervention generation. So seeing them, I can remember I had a fight with NK Mishra actually. Look at them. So that's how they work. They do all of this, and we are not doing anything. So they changed the attitude of a whole generation of neurointerventionists to go out and do it and make things happen, and their meetings. I still remember Lonavala attending this complication meeting he started off. So as I say, he's been a huge influence in neurointervention field, and a whole generation, even people. I may not be that young, but he was an inspiration and to follow and to be very active and aggressive in this field. So let's give a huge hand to Uday. All right, so just to show, blister aneurysms, there was an era when I should treat them with stent-assisted coiling, and which was a big trouble, and I published my outcomes as well. And then we started using flow diverters in these patients. So I just want to take you through maybe one or two videos of how I do it. But to me, the technique remains very, very important in this patient as to from where. So this is the classical blister aneurysm, right? So you can see it is from the superomedial wall of the ICA. The ICA is slightly swollen up. It's not from choroidal or PCOM. When we see any aneurysm there, we know. So we like to do simple FD. Some people internationally do double FD as well. And some people like to place coil. But we have realized now a single flow diverter done well works well in most situations like this. So how do we plan the antiplatelets here? All right. So what we do in our department is, we use double antiplatelets, and usually we just load them before we shift the patient. Our logic being in 2 hours will have effect. So by the time patient comes in, we give anesthesia. These are very straightforward to cross and deploy the FD. Oh, Rajiv is also here. Rajiv, can you join us as one of the chairpersons, please? So Dr. Rajiv Jha is here, one of the senior neurosurgeon in Nepal. But again, one of those neurosurgeons who has been encouraging and mentoring neurointerventionist, and is a great friend of the country and my personal friend. Okay, so what we do is we load them just before, and then we go ahead with it. And to fail, in your department, do you do a preloading or you use injectable for blister aneurysms? How do you handle them?
For blister, I usually give prasugrel 2 hours before the procedure, and usually 30 milligrams is enough. I don't give 60. And then on table, I will give IV aspirin just before the stent is deployed. And that has been my protocol for years now.
Okay. So ours is the same, except that we don't have IV aspirin. We load with oral aspirin, and I've been using 50 milligram Pasul, but we don't have testing available. But yes, we have seen some cases of bruising, then we decrease the dose, but we haven't had any bleeding complications,
So IV aspirin has become very difficult to get now, even in UK. So people are doing either put a nasogastric tube or they're giving per rectal.
All right. So anyway, this is the angiogram, again showing the classical blister aneurysm there. And this topic we were discussing in slice training, from where to place the flow diverter. Do you place it only in the ICA? You develop from the MCA? So my philosophy has been, we always do from MCA. If you really want to compact the flow diverter, I want it well opposed, we always start from ICA, use a lot of force. So distal access is very important. This patient has a huge loop. We use Seribase so that we can take even this loop. And we're taking a microcatheter, over that a 4/4 DAC, and over that a Navian. All right, so we use this coaxial, triaxial techniques a lot so that we get a very stable base there, because flow diverter needs a lot of force to open up. And as I said, where to deploy? We deploy from MCA. We deploy from here. Sometimes the opposition may not be good. We have endoleaks. This patient also had some aneurysmal changes here, so we use the longest flow diverter to deploy up to this segment. Otherwise, usually we'll end it just before the ophthalmic, but this was an exceptional case. With, as you see, there's another aneurysmal dilatation here. So we covered that area. Now sizing becomes challenge here because see the artery is really expanding. You use a large flow diverter, we'll have a problem. So what we decided to use a 4.5, and our attempt was to finish before that dilatation in the cavernous. As I said, they're easy to cross, and we use this, and you can see over this microcatheter we've taken the guiding up. Once you're deployed to this degree, this is where we tend to compact them, all right? And when you're pushing the flow diverter to compact them, somebody should be pushing in the guiding as well. See, now we have withdrawn a bit as Matthew showed, and then we push it hard, and you see how it has expanded here. In the other angle also, you can same thing. We withdraw the microcatheter and we push it very hard, and somebody should be pushing in the guiding at the same time for it to really work. And we try to get even a dark line here, expand it as much as possible in the region of the blister. Again, another of those procedures. So we have really compacted here, expanded here. Now we can see we take an angiogram, good wall of position. And maybe because we manipulated excessively, you can see it was not opening up in this area. And I tried a few times. I think we resheathed it once, as Dr. Matthew showed in morning. We deployed a bit more, kept manipulating, and then we could open it. As I said, we don't like to rely on balloon in the end. You manipulate that time to get it open as much as possible. And again, we have compacted it, so we know we have opposed it well, and then we finish the deployment. You can see it's not well open here. It's not a major ANVI. We always withdraw the micro and the wire, and you can see it snapped open there. And then you use a microcatheter massage, and you can see we sort of shorten the flow diverter here so as to bumped the microcatheter against the wall of the flow diverter. But I wasn't happy about this area. So yes, once you are not happy, it's acute. We did angioplasty as well. You can see some slowing of flow, but I've seen once it's a well deployed flow diverter, usually, and there is not much of a problem. Patients tend to do well. And one thing which I missed, if you can see, there was already a drain placed in this patient. She had mild dilatation, so whenever we have a worry like that, we get a drain placed. It may be EVD. Even if we don't want to drain, we get a Omaya placed. Omaya is something when they place the tube in and there's a sac below the skin, so we can drain it any point of time. What we usually do is we start early morning. We'll tell our neurosurgeons to place a drain at 6. Okay, we wait for 2 to 3 hours, get a CT scan done. If there is no bleed, drain is in right place and everything, then only we load the patient and we give anesthesia and go ahead with the procedure. So that's a protocol we follow. It has to be coordinated with neurosurgeon, so that in one anesthesia we do the whole thing, and it's very gratifying in this patient, a situation which was very tricky to handle in the past. And as I mentioned, one flow diverter deployed well usually is a great technique to handle these patients. But to me, why we wanted to show was plan for a drain beforehand if you have to. Number 2, antiplatelet regime should be very, very clear as to what you are going to use. And 1 second, let me just stop this. 1 second. We'll just tell you how to when to play the next one. And number 3, have a very stable guiding catheter, because if you do a lot of force to open up the flow diverter, your guiding catheter has to be stable. It should not be coming down. And even when we are sort of using force to open the flow diverter, somebody is pushing in the guiding catheter. That's the only way to happen. And if, as I showed you, sometimes it is twisted a bit, not opening, resheath, redeploy, do all your manipulations. And the lower end of the flow diverter, microcatheter bumping is a great technique to get it settled down. And if need be in the end, yes, use a balloon. But as I said, most of the cases, just like Matthew, if you deploy it well, then doesn't need to use a balloon in the end. We'll just show in short another case of blister aneurysm. This patient was actually a MBBS student, and so you can see the artery was kind of dilated here. In other angle, we can see the classical blister aneurysm. Of course, in this case, as I said, usually we like to finish around ophthalmic or just proximal to ophthalmic. That is what we plan. We always like to take a guiding high up so that there is no issue in taking the flow diverter. And so we start deploying from MCA. That is our protocol in all our cases, because that's the only way we feel we can really get greater position in the region of the aneurysm. Again, you can see we want to create a dark line here. Again, the same thing. Guiding is high up, and you use a lot of force. You want a dark line here in the region of the blister if possible. So we do all our manipulations. So you can see I love this dark line. I know then in this region I've really sort of compacted the flow diameter a bit. And once you deliver the lower end, very frequently this is a pipeline device, it doesn't open, then you can use microcatheter to open up. It's usually not a major issue. So lower end you deploy with some force, and you can see it's not well open. Again, you use microcatheter and manipulate the microcatheter to and fro like this, as Matthew also mentioned, to open it up. With the wire, microcatheter goes into the aneurysm, but then you can take a Traxxas wire and then use the edge of the microcatheter to bump it a little bit more. So we love to do this massage and manipulations and to get it right in the end. And this was the end result in this patient. Again, you can see slightly overexpanded but very compressed flow diverter in the region of the blister aneurysm. And what we realize in most of these cases, one single device is a vaso-CT, not a great image. For vasospasm, we had to do an angiogram after a week. We don't usually do early angiogram, and the aneurysm was all gone. And in our experience, yes, we do cover the anterior cerebral artery in these patients, but usually there is ACOM, and to me, a bleeding complication kills a patient. So, but you have to cover it, and usually since slightly oversized flow diverter ACs remain patent, or they get taken over by ACOM. Initially, it was a worry for us because in subarachnoid hemorrhage, their vasospasm can also come in, but somehow we have realized it has worked well, and we don't get too many ischemic complications in these patients. So, this is how is my department's technique in handling blister aneurysms. So, we can have some comments. Somebody would like to use 2 flow diverters. Does somebody use coils with the flow diverters? Anything different one would like to do? Yeah, Tufel.
So, if it's a blister aneurysm,
yeah,
I usually, if I can, I try to get a coil, and sometimes it's impossible. But if I can't get a coil in ICA, there's no, for me, I will always put another flow diverter in. And I can show you a case where you have not done also, when I haven't done it, I had a rebleed. Okay, and I can show you a couple of cases like that, where you have put only one flow diverter, blister aneurysm, and bled 3 months down the line too. So single flow diverter, I think it is not necessarily absolutely protection. You may be protected, but you still have a risk. So where cost is not an issue, I just put 2 flow diverters. If it's a blister without coil, if I get a coil, then I'm much more comfortable putting 1 flow diverter.
Okay, so I used to do stent-assisted coiling, but I mean, and we've done quite a few of them, but you know, trapping a microcatheter in the small ones, placing a coil.
Of course.
So, and that is why I wanted to bring this up to discussion. What we realized, a single flow diverter really works well in our hands. When it's a biggish aneurysm at times, then I do place coils. You know, I either with a balloon or just trapping a micro with the flow diverter, we place a few coils. We have had one case of rebleed, and that was the case I used nitinol-based flow diverter. So, and usually I use cobalt chromium-based. Pipeline has been a favorite in this particular situation. So maybe I became superstitious. All of them work very well. I've just come back and I don't use nitinol-based in these acute SCH in these blister cases. But I don't know, maybe all flow diverters work the same.
If you put a 1 flow diverter in a blister aneurysm and it's okay, but I don't think you can call it completely protected, because you will have patients with a single, they are on double antiplatelets, you got a single flow diverter. In fact, if you don't see filling of the aneurysm, still not protected. Because these blister aneurysm is a disease of the wall, and I have seen cases where there was no filling of the aneurysm at all. Nothing. You had one stent, didn't fill, there was stasis at the end, and patient rebled. So if you look at the literature also, it's very difficult area, but it's not a surgical target, and it's purely endovascular, because surgeons would wrap it, and you can correct me if the surgeons are here, but I am not convinced that 1 flow diverter makes the difference, so I always will put a 2nd flow diverter.
Yeah, Vincent.
I'm doing exactly like Vipul. I think the very important message you gave us is, if you want to do such a case, first you need to check if the patient will need or anticipate the need of a ventricular shunt, and to make the ventricular shunt being placed by the neurosurgical team before you load the patient. The literature, the data report up to 24% of bleeding placing a ventricular shunt and double antiplatelet therapy, whereas you have only less than 9% of hemorrhagic if you do it before and after you load the patient. So this is, we don't have data for one or two flow diverter because we don't have the answer. I put only one, and I have to say we're happy about that. In the literature, flow diverter in the hemorrhagic situation, rebleeding rate in the first 2 weeks is 4% in the literature. So there is rebleeding after flow diverter at the hemorrhagic and during the acute phase, but I think it does not justify 2 layers systematically because you increase also the thrombogenicity of the procedure, and you don't. So that's also something we should consider as well.
I agree. None of us have done, at least I haven't done 100, maybe I've done 40, 50 of blisters overall by now in all those years. And we had one bleed. So one would say, yeah, maybe we also have 2 to 4% rebleed rate. But whether it's a belief that using a lot of force to compact it and get great opposition really helps in preventing getting away with one flow diverter. But again, I don't know, and Tufel is right. Maybe in next patient I have a rebleed, I will change my protocol.
Yeah, Dr. Tufel, just one more clarification. Like the coiling, the blister aneurysm, because this is not a secular aneurysm, and most of the time it is small. Yeah. With your expert hands, yes, you can put coil safely, but putting in a coil in a blister, the intra-procedural rupture risk is too much.
No, I totally get that, and I think that's why you have to be very confident and safe. And if you are not happy or not comfortable, then I think you should not attempt it at all. I totally agree. And in fact, because I have seen rebleeds from blister, and I do a lot of medical legal work and a lot of expert, I work in a litigious world, and we were talking about it. You know, the lawyers are always after us, okay, in UK. So you have to be so careful. And whereas it's different in different countries, but in UK...
In our country, families go after us, which can be even worse.
But families here will probably just beat you up. But, you know, if they beat you up, you can take some beating and then you're okay. But when they sue you for £1 million, then you can be in trouble.
Let's ask Uday, just to comment. 1 FD, 2 FD, FD with coils.
Good.
What's your first choice?
Yeah, good you asked. Never go with the idea that I'm going to put 1 flow diverter or 2 or 3. So always look for the morphological change in the aneurysm. Stasis, non-filling, flattening, there has to be a definite morphological change which we watch for. If there is no morphological change, then the aneurysm will bleed. And I have seen a few. And so that is the one thing which we absolutely watch, 1 flow diverter exactly like you do. But there has to be morphological change in the aneurysm. And the last thing is, before discharging the patient, we always do a DSA.
I think that's also some good idea.
I wanted to make that point. That's a good point.
If any chance you see too much filling, growing, these aneurysms can change very quickly. It's a very good idea it sort of settles one's heart that, okay, most likely things will remain fine. This is a very tricky disorder. In era of FD, it becomes so much more easier to handle than the past what we were doing, 1 stent, 2 stents, coils, this, that, recurrence and all of that. But we wanted you to also know that there are different protocols, and we have a protocol. As long as well open, you know, small aneurysms flow change, even when there is a hemodynamic change, we may not see it angiographically. That's how the physics. So I would love to see that. Even if I don't see that, if my flow diverter is well opposed and everything, we are okay with it. That's what we have been doing. But as I said, nobody has 100, 200 cases data to share that your protocol is the best. And so we can let it lie here. And all of you have heard different opinions. You have to form a protocol and sort of see how it works for you.
But the important thing is follow up what Uday said, and you're saying, but we also have a protocol. Usually if I have a blister aneurysm and I put 2 flow diverters or flow diverter with a coil, I usually do an angio or a CTA at 24 hours. Usually then I have another one at a week. Then I usually do one at a discharge, and then I do one at 3 months. So that's our protocol. And because we are very aggressive in making sure, because you can rebleed. I can show you cases where patients have come for a follow-up at 3 months, and I have a patient who came for a follow-up at 3 months and bled in the MR. So these things happen. So I think we have there is a policy across UK to follow them up very rigorously.
All right. Great. I mean, Vince.
There's just one point, because we don't see the disease and we are only looking at the luminogram, the trap could be to underestimate the length of the disease, meaning that you want to stent and to cover with the flow diverter, and you are too short. So when you are doing with the flow diverter, also it's very important to cover very largely from the M1 to the carotid, because we saw a case where we thought it was cured, but the dissection just progressed distally to the lesion. So because we're working on luminogram today and not with the intravascular understanding of the whole disease, it's very important to be sure that you're covering the entire disease.
Absolutely agree, and we don't mind as long as, if in doubt, please use a longer flow diverter, number one. Number two, in these cases, since we compact a lot, we lose the length. So we don't care, let it come back, even overlaps ophthalmic is fine, but you have to get a great wall opposition, particularly in acute stage, and you're going to play in a CSF drain in these patients. And as Tufel laid out, I mean, one can have mishaps, whatever protocol you have is a deadly disease, and one can still have mishaps. And so, I mean, as I said, maybe we don't have the perfect answer, but these are the various approaches, and that has been our approach till this moment. As I said, tomorrow one case rebleeds after a perfectly done, maybe I'll change my protocol and start following something else. That happens all the while. We can never be dogmatic that whatever I do is fine. So, okay, so we'll go on to the next session. I mean, so we are doing some unusual situations, so which will be now, we are talking about distal aneurysms here, when you do deconstruction, when you do reconstruction. So let's go through this patient. This 55-year-old male with ventricular hemorrhage. Again, you like to have a drain hand. This is the kind of aneurysm, this is the pica, right? Pica is whole irregular, and this kind of aneurysm is there. So it's a big question now what to do with this artery. I think there was a mistake in the age. This patient was around 25, 30. I remember this very well. So what will be our approach? Deconstruction or reconstruct? And if you want to reconstruct, how do we do it? I mean, Uday, how would you?
Can you show the pictures again?
Yeah, let me go back.
Yeah, let the picture be on the screen.
Yeah. This is a big pica. You can see a lot of branches coming out of it.
Ruptured.
And ruptured, acutely ruptured, fourth ventricular bleed. We got a drain in, yes, but what to do?
So as always, you know our opinion. As always, reconstructive or making patency of the artery is supposedly safer. Supposedly no one wants to occlude. But a deconstructive technique is not just sexy, it is actually very effective.
Yeah.
And so distal picas, they will have on the surface of the cerebellum, they'll have collaterals from the scar.
Of course. So that is very important. Distal picas, we have done a lot of occlusions. We do few reconstructions. Acutely ruptured distal pica, and usually they do very well with parent vessel occlusion. We don't even do testing. We just go ahead and occlude this artery. But this was slightly proximal. This is where perforators can be there and everything there. So.
But if you can always inflate a balloon and actually do a BTO.
Hint, we are in a flow diverter session.
Dr. Vipul, the proximal artery is also not healthy. From the origin to
it's irregular all over. So point is, even if you occlude here, is it patient really safe? This was very irregular artery.
This is irregular artery.
Yeah. So let me carry on. Of course, there are no simple answers. So we decided to, and this was a big pipe, a lot of branches, young patient. So we decided that we'll go ahead with the reconstruction attempt in this patient. The biggest challenge was how to cross this aneurysm. It wasn't so easy. And I absolutely believe in very, very distal. We access, again, as I said, we get EVD or Maya done. I really love distal access. Yeah, it's saying battery is running low. Excuse me? Battery. All right. So we'll keep all these wires. Sometimes I even like to cross them with a hybrid wire. Once you get a micro across, is fine. This is super curved synchro. We love synchro. We'll give it like a tight pigtail shape. But this took long time. I kept struggling. And I thought whether I'm going to end up rupturing while struggling. You took an angio. Then I placed a balloon in the vertebral so that I can control the bleeding if need be. If need be, bleeding happens. And then with super cut, somehow we were able to cross it. And in the other plane, it was very useful to see that the wire is going around. You give it a torque, slight pressure, give it a torque, and slowly it may travel distally. So this was a lot of trouble, many wires wasted before we really managed to do it. You can see how crumpled the wire is because we get a very, very tight pigtail, as tight a loop as we could, and that only helped us to cross the lesion. Now the straighter part of the wire comes in. You can see we just torquing it and slight pressure keeps going in, and then we were able to navigate a headway catheter into the aneurysm. Now, also when you're doing FD in such, you want to worry about the distal, and you see the whole artery position will change once you place the microcatheter. That's a Vista baby. Whole artery straightened off, but we know it will reform when you deploy the fluid after force. It reform into its original configuration. The challenge here was to get it right absolutely to the edge of the artery because the artery looked diseased. But when we tried to deploy with force, it hyper-expanded in this area of the aneurysm. At a turn, we had to use some force, and as soon as we use the force, it will bulge into the aneurysm like this. I wasn't comfortable with this. It was sort of bulging into the aneurysm too much to my comfort. So we decided we'll resheath and deploy with slightly less force and see how it goes. So we resheathed it, and as I said, we kept a balloon there. You needed to support microcatheter, number one, and number two, in case of any bleeding. So that's a hyperglide which is there in the vertebral. Now less force, even then it was bulging a bit, and I realized I have no choice. And we realized maybe we'll end it at the time you took an angiogram to know where you will end. And we decided to complete the deployment right at the origin of the pica. And you can see slight fish mouthing of the tip of the flow diverter. Use this gentle massage, use this up and down movement to sort of snap it open with the wire and microcatheter, some gentle massage of the microcatheter tip. We didn't want to push too much, and then it's okay, it settled down, and we were pretty happy with it. We felt there was some clotting happening here. I placed micro, gave a little bit of injectable interplated agent. We watched it for a while, and thankfully this patient did well. This is CT scan on the table to look at the device configuration. Maybe the proximal end is not perfect, but we were sort of okay with it. And I think we have a check angiogram of this patient as well. I think this is during the stay we did a check angiogram, like sometimes we do in ruptured aneurysm. What's really happening is an early check angiogram, and then I think we have a delayed check angiogram. So whenever we extubate such patient, we tell them to keep. This is delayed angiogram. So this stenosis in the artery, but it remained patent and patient remained fine, and ultimately he has done well. So we can. Anything we could have done differently,
the stenosis phenomenon? Can you show us the angiogram with the stenosis?
The last one?
Yes, just to understand what happened.
I don't have better.
Where is the stent here?
So stent is here, up to here, I think up to here, and there's a lot of instant stenosis. The artery has become smaller as well overall.
So my understanding is probably there was a collaterality, do you think?
Yeah.
I mean, I would have been really afraid to occlude this artery as well, but I see that probably it could have been done, but I would have been conservative as well, but probably yes. You see, it was an pica, as I understand.
Yeah. ICA was very small. It was a huge artery.
ICA and pica artery, so very huge artery.
And problem was, it was all diseased till the proximal. So if you don't do a focal occlusion, you can't coil the whole artery.
Yes, it was true proximal.
Young man.
Very interesting.
It was like mid-20s, 30s.
Very nice case, huh?
But just wanted to show how synchro can really help at times. We love synchro while we give it a super duper curve as much as we can make it into a pigtail. And then somehow it talks well and slowly, but it was quite like a treadmill test to cross that aneurysm. So that's why in between the case we prepared a balloon and placed it. Worst come worst, we rupture, we inflate the balloon and close the artery and get out of it. Yeah, to fail.
Well, I know you always talk about being very conservative and safe, but I think in this case, all the manipulations were quite risky. Good in your hands. Probably I probably would have tried the same maybe, but I think when it was going like that, you need to still consider parent vessel occlusion. It's probably the easiest and the safest technique. Just close that, and you're not doing any manipulation. I don't know whether you have a long-term follow-up on this. Sometimes you put these small stents in these distal vessels, you follow them up, and they are occluded. So you get a very expensive occlusion. So
you're absolutely right. We have also some small stent occlusions. You are absolutely right. And it's a little uncomfortable at times. You place them perfectly and they occlude, particularly in acute SS situation. You are absolutely right. We have seen that as well. Number one. Now, only worry in this case was a big pica, like big pica, and the whole artery was diseased. So I was worried about perfect occlusion. But yes, 80 to 90% of distal pica aneurysms, we still do PVO. Maybe we should have started with the PVO case. I don't want to send a wrong message that all these cases we try to reconstruct. No. This was proximal, and I thought I had to coil till the origin of the pica because the whole artery was diseased, and I was very uncomfortable about that part. And we started this case with this, okay, we'll try this. It doesn't work out, we do PVO and come out and everything. But yes, it was very tricky. It was very challenging. I absolutely agree. And acute SCH with time, when this 17 micro fluid diameters came in, we were very enthusiastic, but we have seen acute and chronic occlusions both, particularly in acute SS situations. So with time, I have become a little tentative that even if you deploy the device well, outcome may not be great.
I think one of the things is when this artery moves.
Yeah.
Okay, and when you move, you can pretty much share the artery at the origin too, because I have very recently done exactly what you are doing. I got carried away, tried to reach, and as I managed to reach distally, I had one of my fellows with me, and he said, "Oh, it looks okay," but I saw the shift of the artery. The whole curve had gone suddenly, and anesthetist said nothing. And I said, I think I've ruptured this.
So,
and it had ruptured.
We'll quickly show one more flow diameter. What you mentioned is absolutely right about artery moving, and it really frightens me to use this thicker regular wires. So quickly go over. This is a 54-year-old female. I think she was a doctor herself. Again, as I said, don't send a wrong message of placing flow diameter and all, but this patient again had a huge pica, and we have done a reconstruction. But I want to show that as Tofela just mentioned, artery moves and is very uncomfortable in acute SCH, these arteries moving around. Initially, this looked like a great, and again, a very lot of big branches coming in, so we thought we'll reconstruct. And but when you place a regular wire, your 12 wire, Traxxas wire, Synchro 14, all these artery moves a lot, which makes one very uncomfortable. The standard protocol, if we have to we get a drain in, and we get a big guiding right up to the pica origin, so as to give us good control. That is very important. To get Fargo max up there, you have to have your neuron max into the vertebral artery for a while, then only the guiding really goes up and in a stable position. Now we know we are in there. But in this case, as soon as used a wire, I'll show in the pictures how the artery started to move, and I was very uncomfortable that what am I really catheterizing now? You're not even sure whether the artery has all moved around, while this looks like a big pica. So again, we keep even 08, 01, 0 synchro we love at situations like this. So you see how the artery is moving? So now you get the point with and this is very uncomfortable, right? I don't even know where to take the turn. So I took out this wire and I use a synchro 10. So in this case, I switched to a smaller wire. This is a headway. Take a new road map so you know where you are, and use a much softer wire now, like a synchro 10, to cross it. So which leads to less movement and slightly more comfortable and less traumatic in these very small vessels. So,
Vipul, we have a neurosurgeon that stands, so we could ask him whether he would consider bypass and parent vessel occlusion.
Okay, so I'll stop the video here. What you mentioned is a perfect solution. The problem is India have never seen anybody doing pica bypass. At the best, all we have seen is STMCA or ECMCA bypasses. I haven't seen anybody doing ACA, pica bypasses. We just don't have it.
We can ask Rajiv what is.
In my opinion, most of these pica aneurysms, they are associated with intraventricular hemorrhages.
Yeah.
So issue is not only aneurysm, dealing with the aneurysm, but also to manage the hydrocephalus. So definitely, and these pica aneurysm are not difficult to clip also. So what is our, as a neurosurgeon, definitely practice is we first put this external ventricular drainage, and then definitely we do the permanent, occlusion, that is clipping. And the best treatment is definitely if you have some bypass surgeon, then that's the best option.
Yeah, but at least, I don't know, PJ, are they doing
Yeah,
any bypasses
Dr.
for smaller
Vipul,
vessels?
I just wanted to add another point, like unlike the MCA, M3 branch or ACA, A1, A2 branches, they are very much supported from the brain parenchyma outside. But these arteries in the posterior fossa, they are just lying freely in the subarachnoid space. So they move much more when we try to cannulate them and try to go distally. So they got straightened, and there are higher risk of vessel injuries because when we go distally into the M2, M3 and those branches, they don't they don't change their course. But in posterior circulation, yes, they do, because they are lying freely in the wider subarachnoid space. And if they bleed more, because there is no tamponade effect of the brain there. So this is the point I wanted to add.
I think in this
because
case,
you took the next run, and because the anatomy is totally changed, the first when we took. So that is something looks very risky.
I agree, these are uncomfortable. And if this was a smaller pica, as I said, again, maybe, it's a flow diabetes session, you are showing a couple of pica cases, 90% distal pica we occlude. Only when we see a very huge pica at times, and like the first case, proximal ones, we think about reconstructions. So maybe I've done only 3 pica acute cases of reconstruction, 2 of them I'm showing here. So rest, we have all done PVO. PVO is great. Even if there's small ischemia, they all recover very well, all right? So let's not take away that from PVO as a first option and everything. But as I said, and here you have to be very, very careful. Your fellow or whoever with you, Dr. Rashmi was with me, keep an eye on the wire, because here you're talking about this wire is into one branch of the pica now. So very, very carefully, and you take multiple runs to see that everything is going well. But yes, flow diabetic delivery in this case was pretty straightforward. I mean, there was nothing much to it once we went across to deliver it. And she was a young lady, as I said, young doctor, huge pica. So we had decided on preserving it. And this one wasn't as tricky as that one to do. And there is some stasis in the aneurysm. We debated whether we want to place some coils in there. We thought maybe we'll complicate the procedure too much. There was quite a bit of stasis and flow change immediately. As I said, no heparin post-op. We reversed the heparin, low blood pressure in extubation. And this is 3 months follow-up. Most of the aneurysm is gone, well preserved. In this case, no stenosis of the aneurysm and anything. So we've done well. So yes, let me start from there. 90% of pica ruptured, we do PVO. It's a great technique, safe, effective. In those cases also, I sometimes use synchro 10 wire to catheterize, not to traumatize the artery and everything. Only when it's proximal, and like in last case, it was again a huge pica, doctor, working gynecologist. Okay, we do a reconstruction, but PVO works well. And as we discussed, yes, long term, what happens with the small stents, we are beginning to understand now. Or we are beginning to know that we don't understand now. Let me put it this way. So that is a very, very valid question. As Vincent mentioned, maybe that first patient had collaterals, or whether collaterals develop over a while, they tolerated better, maybe. And as Tufail mentioned, these are not easy procedures. These are high-risk procedures. So we just wanted to show some technical aspect, that distal guiding, balloon in hand in vertebral, using O10 wire. You don't want to push your 12 and 14 wires into this pica. And during the delivery, you have to keep an eye on the distal wire is going to a small branch. And whatever you may do is still have a PVO or a stent stenosis or arterial occlusion on hand and follow up or immediately. These are all to be kept in mind. Yeah, Tufail, you want to say something?
Well, I think you made a very good point here, saying this patient was a doctor. Yeah. So you change your attitude, and because of the VIP syndrome. And I think it happens to all of us, because we sometimes ignore what we have been doing because of somebody we know, somebody from the family, or somebody is important, and we modulate our practice because we think there is a small rest. But like if you see that your last angio, there is still some small nipple there, and that means you still don't know at that stage whether she is protected because there is still some blister there. And that is a problem because we all have done this. In years of experience, then we do the same thing and suddenly somebody from a family comes, we change our attitude, we don't want to do it, what we normally would have done, and I have got into trouble too. So, and you think, wish I had done it different. Especially happens when it's a consultant colleague, or somebody with you, and then you operate on him, and you change your practice, and then it affects it.
Again, maybe we should have shown more. This was a huge looking pica. As I said, still PVO is great. You offer those options to the patient. Sometimes it looks like a big pica covering a lot of cerebral hemisphere, and you worry about collaterals being enough. And the second case wasn't that tricky. The artery was quite straight forward. I think, but that doesn't mean we have a hammer and nail and we have to use it. You are absolutely right there. It is like cavernous aneurysms. Come on, we discussed in the slice training course, PVO with a great ACOM, PCOM, with a great ACOM, no venous delay, to me is one of the safest neurointervention I can do, right? Then why are we placing flow diverters which have anteplated issues, less occlusion, more mass effect issues? We are trying to reconstruct. So we are in first case I'm convinced. I would like to occlude that pica. At the best tendril thrombus we'll do a PVO, right? Okay, all right. And reconstruction versus deconstruction, yes, I still offer all my cavernous aneurysms PVO. And I quote them less complication chance than a flow diverter. If there's great ACOM with no venous delay, I think PVO, cheap, easy, local anesthesia, 20 minutes procedure. That's it, right? Only when I see a very huge pica, not like ICA pica. This patient should have moved from Israel, a huge pica, a lot of cerebral hemisphere filling through it, young patient, highly functional patient, even if they have, and this didn't look like that difficult a reconstruction. Maybe it's a choice, but I don't know the right answers. I can't claim to be. Vincent.
No. I think the two cases are different. The first one was dissecting aneurysms with a large disease. It was not only the aneurysms; all the rest of the artery was sick. Yeah. And in my experience, when the artery is sick like that, it's very unlikely that when you occlude it, you have a problem. I don't know why. Maybe the flow is already changed after that, but it's very rare when you have a dissecting vessel that something happened. Almost never. And the other one, we thought it was very punctual problem, it was very small. The neck was large, but the disease was really focal. Yeah. It was straight, the diameter was larger, so the risk for flow diversion complication, size of the vessel as well, the importance of the flow. So it was for me a very good indication to try to keep the artery patent, especially because he's young. I think it's also something we need to take into account. Yeah. And she needs all his brain at his maximum to continue his career. So yes, I understand that you want it to be conservative, and we have the tool because the O17 microcatheter with a flow diverter, it was not there before. There is an alternative to that. It's just to put a braided stent, like a Leo or like a Evo stent from Microvention or Leo from. It could be an alternative because there is literature showing that just braided stent without being flow diverter is enough to reduce that kind of aneurysms.
Yeah, so I think Vincent made a very important point. Sometimes we worry about perforated, but dissected segments, the damage is already done. And patients tolerate it, or already there's an infarct and it's done. So we should worry less about perforators. That's an important point. And Tufil made an important point. I may be happy showing, look, it's largely gone. But as long as any aneurysm remains in ruptured, we are in danger zone, right? And that's an important message for us to carry, that we can't ignore that point, that there is still some small amount of residual aneurysm. And third important point, as again Vincent made, was in smaller aneurysm, even British stents work like flow diverter, something like Evolve, with even a smaller holes than baby Leo, maybe even better. So sometimes, but only thing, we debated that point, and I'm more comfortable in safety with the British stent any day. Only thing was largish aneurysm. So I would have liked to place some coils with the British stent, and I thought 2 micros here really complicate the situation. But yes, in smaller vessels at times, British stents work very well. And as you saw here, there are no right answers there. If you have any doubt, PVO. You've got two masters sitting here saying PVO. Uday.
Yeah, sticking to the point, you made the points already, but sticking to the point of your great use of synchro, we have a very low threshold of shifting to the hybrid 7J. Absolutely atraumatic, it is fully J, curved on itself, and it's never going to catch something or perforate.
So that's a great thing again. Please don't use regular wires, whether we use synchro 10, sometimes we use hybrid, it's that J wire. Be very conscious, these are smaller vessels which we may cause injury pretty easily in these situations. So now let's go for small vessels to some big vessels and where we had a problem. Now this was 80-year-old female. One may argue that why we were doing it. And she was actually an international patient, and for all my persuasion, the family and the patient were very clear. It was symptomatic and for treatment. So, and look at the anatomy, tortuous anatomy. But we thought once we are up there, the aneurysm looks okay, and collateral was there, but not too great. And we went in for reconstruction. Very tortuous anatomy in excess. We had to use SIM. Even from radial, the angle wasn't great. And so in these cases, we use SIM, and then usually sometimes we'll use an Amplar's wire and to keep things stable, to get her guiding up. But as I discussed in the morning, Amplar's wire, we don't form a loop in the ICA, either in the CCA or in the ECA. And over a coaxial system, you get a long excess sheath, and then one is in game, and the sheath has to go into the ICA. But in this case, we thought excess is the only issue. After that is straightforward, but trouble started later on. Okay, and when so many loops are there, I just use a 5F catheter to go across. So usually we take a microcatheter, 3A distal access catheter, followed by a 5F guiding, and you can see even then the manipulation of the sheath was beginning to get unstable. And so I think that's the 3/8 microcatheter. Then sometimes switch to a stiffer wire, and we have managed to get our 5F there. And now I thought it will be straightforward. We want to place a flow diverter. We thought it was a straight segment, and this was a artery was pretty wide. This was a derivative stent. But as soon as we came to this area in the clinoidal region, and it wouldn't open up, and the catheter will sort of twist there, and it will behave like this. You can see the stent will just twist there. The whole thing will just rotate and it will twist there. We tried many times. I tried push, pull, we resheath, re-delivered, again resheath, again re-delivered, different forces. And while it looks straightforward, in this region, if you see, it is the flow diverter kind of twist. Now looking back, maybe we should have taken distal access more distal, but the proximal access was so bad, we were not able to manage. And after a lot of struggle, it was just opening up to this degree here. Lot of manipulation, and we thought, okay, we'll do angioplasty in the end. And now I will stop here. Now problem is, when we were focusing there, and we delivered this end, I think as Winston showed in the slice training, I think I delivered with too much force. Now what happens even when we are experiencing and you're struggling with the device for a long while, one tends to get excited, okay? And sadly, I didn't even notice this end was like this. And I tried to cross it with a microcatheter, and I damaged it even more, all right? And then we saw something is wrong, and what we did was, without contrast, we decided to do a CT scan on the table to understand what was really happening. And you realize how this end, by initial delivery and our manipulation, we have sort of destroyed the end a bit. So what we did was, we used this vaso CT, and we rotated in multiple planes, and then we decided that is where the hole is, and we can enter safely. So we use this CT scan image to enter the device, and I use a hybrid wire over a 17 micro catheter. All right, like Uday you mentioned, soft, very soft wire, didn't try with a 27 micro at all. So we used a very headway micro catheter, I think it was duo, with a hybrid wire, cross it softly so we don't damage the stent anymore. And then we did angioplasty in this particular patient. So this is a case of fish mouthing, but delivered by extra force and because of our excessive manipulation. So So this is we created two views where we realized if this angle it goes like this, then we are safe. And then over a 17 microcatheter, we were able to cross with a very soft wire. Then we exchanged with the balloon. And with one angioplasty there, the stent expanded, at least it was comfortable, not still perfect, but comfortable. This was in the aneurysmal segment. And then we came proximally.
What stent was this?
This was Derivo. And we did angioplasty here as well. I don't have the pictures. After angioplasty, we did another vaso CT, and it looked reasonable. I watched it for a while and left it there. Didn't deploy a stent, as you mentioned. And now we were happy, we are done. And then what do we see? You saw it?
No.
Okay, sorry. Let me go back. Something we don't see often. Let me go back here. Let me play it for you. And just when we thought, okay, now we are done. Ajay, what's missing? Motor cortex artery embolism. Come on, this patient was on ticagrelor, heparinized and everything. Now we have embolism in hand. Now what to do?
Just put heparin.
Huh?
Just put heparin. Microcatheter is right there. I would
Yeah, yeah. So
be very aggressive here.
So we took the microcatheter and we injected some injectable interpolated agents. Usually that works very well in our experience. This is acute platelet clot. It didn't open up. So in desperation, I made another puncture and we decided to check for collaterals. And that is where we were, I guess, lucky. And we had a great collateralization and we left it there. Okay. Now question is whether this patient did well ultimately. We did multiple angiogram. Now the inferior end looked fine. Maybe still not perfect, but we left it there. We didn't place a stent there or solitaire there. And that was the end of the story. So what do you say, Vincent? Solitaire?
For the distal emboli?
For the distal emboli, I mean, what more could we do?
No, because I think we're in a kind of secondary distal vessel occlusion. I mean, we have no level of evidence that this occlusion that is very distal is harming very much the patient. So I think one solution could be to awake the patient and to evaluate the patient, because you are under double antiplatelet therapy. You will go very distal, making a stent, making a thrombectomy. There is chance that it is working because it's just very recent. So it's a red clot. So there is no. But you still adding something more to the procedure. You will have to pass through your flow diverter. I mean, I would probably just do pharmacologic, like you did, depending on the complexity. If it's really straightforward, it's a proximal M2, I will make a pass as well. If it's very distal, I will maybe look at the angiogram, see if there is no collateralitis, as we said this morning in secondary review, assess collaterality, assess functionality, and make your decision. You did what you did. It was anatomically, it was distal. You tested the collaterality. It was good. So you could.
The challenge was with all that heparin, injectable interplatelets, ticagrelor in the system, making the puncture. So we always do ultrasound guided puncture. Thankfully, my team always have got this peripheral IR guys. They're very used to ultrasound guided puncture. You have to make it a very, very careful puncture at that point of time. Yeah, Ajay.
So, Vipul, the proximal end, what I feel in many cases with us also, while we try to bump the proximal end when it is not opening, so while trying bumping with the catheter, many a time the proximal struts, they like tilted or moved inward. So this is what we can see
so
on the expert CT.
We delivered too much with force. And we were so focused on the stenosis, I tried to cross and I made it worse with my micro. It was overlapping the bone in that working angle.
Yes.
So the message is that fish mouthing can happen if you deliver the proximal end with too much force, and in bumping you may distort it even more. And so I mean, Vincent, when all do you see this kind of fish mouthing or stent distortion at that lower end? I mean, what are the other situations it can happen?
Yes, it's exactly what Vipul said. I think there is two types of fish mouthing. There is the mechanical fish mouthing related to an excessive manipulation or discrepancy between the diameter of the neck and the size of the vessel. And this is also in relation with the anchoring zone. The length of the anchoring zone, the longer it is, the less prone to experience distal fish mouthing you will have, since the stent has time on the distality to spread the difference of force induced in the aneurysms, to make a repartition of this force in the length of the stent, the distality. If you have a very short anchorage in distality and a large diameter into the aneurysms, then the modification of the diameter of the aneurysms is, it's just the flow dilator is just one piece. The braid at the end is the same than the beginning. So each time you do something at one part, you're modifying a little bit the rest of the structure. So if you have not this anchoring that is too important, then you are pushing on the stent, then you are fish mouthing the distality. So first, there is the distal mechanical fish mouthing. There is the proximal one. The proximal could be because of non-opening, but the massage can solve it. And the problem is that if you want to make a massage too strong or too brutal, you can, because there is a gap between the wire and the micro, you can take a stress with you, and what we saw, and then you disconnect the stress from the other one, and then you are destroying the mechanic of the stent. And now the stent is sick. Okay, this is the mechanical one, and there is the, I would say, the biologic fish mouthing. This may come in a delayed fashion, where the healing process of the tissue is applying forces to the stent, and stents will be changed in shape because of this healing traction that will occur on the stent, and especially in the young people, especially the women. So it's different type of deformation of the stent: acute for mechanical reason, immediate, and in the second way because of the healing process.
So Uday, we were discussing in this slice course this kind of distortion of the stent, and I practically destroyed the end of the stent a bit, truthfully. Should we have deployed a solitaire or any other stent there?
But that's the thing you can do. This is such a long stent, and it's reasonably well opposed arthroplasty and everything. You have had a small problem, distal embolus. You don't want to pull the entire construct out.
No.
So,
no, I didn't want to pull it out,
yeah.
for sure.
So that's the only other thing that you can do. You watch it for half an hour, go out and come back, or maybe repeat an angiogram and see if everything is okay, I will leave it.
I think this is what discussed in the slice course, and Professor Mason made it very clear. If you have any doubt about this end, we left it there, and then solitaire, Atlas stent is a great choice there. It's got good radial strength, and it will, this end which we have sort of destroyed, the integrity of the stent, it will oppose it well, and it works very well. So fish mouthing, as I laid out, you deploy the stent at the curves, it can fish mouth. You deploy too much force, it can fish mouth. You use a microcatheter to manipulate, you can distort the stent and fish mouth, and and Dr. Vincent said that on follow-up, intimal healing at times in younger people and says in women, it can lead to distortion of the stent. In acute phase, if you have any doubt, one can deploy a laser cut stent with a good radial force to oppose it well. Just one small question and then I'm done with this. Why do you think we had problem in opening up the stent in that cavernous area? Why it wasn't opening up?
For me, it's twisting, I think.
Yeah.
Because the risk factor for twisting is curvy access and long stent. Because what's happening when you are putting the distality of the stent, you are anchoring your stent. Okay, that's fine.
Yeah, you
but
can see
your
this here.
your micro
It twists here.
But yes, but your microcatheter, in order to arrive in the M1, it did like this, like this, like this, and finally get the M1. So in M1, you are deploying 1 centimeter, but the stent is fixed now in this direction. But the catheter, when you unsheath, is not unsheathing like that. Is unsheathing like that because he wants to come back to his normal trajectory. But here, you are transmitting the rotation to the stent. So the stent is rotating with the restitution of the microcatheter, and then is twisting. So that's a normal, that's an obligation to see this.
So what he's saying is, one view may look fine like a straight artery, but the other artery, the curve is such that catheter, when it comes to this area, it twists a bit, and it's a long stent, and microcatheter twist a bit and rotates the stent. And I changed the stent. I threw out one stent, used another one, whatever
Was
I
the
could
same.
do. Whatever I could do.
Or you can do 20 times. It will be the same. I did it in vitro as well. It's exactly the same. So the only way, what you did, is that after, if the stent is not that much attached, when you will plast him, you will force the braid, to untwist by plasting it.
Yes.
That's what you did.
Yeah. All right.
Just a comment again about your twisting. This is DFT, right? This is Derivo DFT. And Vantage is DFT too now, isn't it? Right? Nadine? Vantage?
I think, Raj, we will let go of this one.
No, it's cobalt.
We'll go to the next one.
Yeah, but the twisting is long stand is not uncommon. Yes. And I see it very often nowadays in Vantage too. So you have to untwist it. And I had a couple of times when I have learned how to untwist it. Long stand, you need to pull it back, straighten it up, to remove the tension so that you untwist the twist,
Oh, yeah. Okay. So I've got one more thing, one more case. So we have discussed about fish mouthing a bit, we have discussed about twisting a bit, and this is the one last short presentation. Again, an old lady and no collaterals, ophthalmoparesis, and one can see there is something happening here as well. Okay, no collaterals, there were no good ACOM, PCOM. How do I go? All right, and there's a stenosis there. What is this stenosis? Is it a thrombus? Is it a fibrotic band? Is it atherosclerosis? I mean, what are these narrowings associated with some of these aneurysms are likely to be?
How it is on 2D image?
Can you show a 3D because that will be overestimation.
Let me go. No, it was a bad one.
No, that bad on 2D. Yeah.
In one plane, it was really bad. Okay, it is. Of course, it's not so bad as this, but it was a severe stenosis there. Yeah.
Well, I'll tell you what I have done before you show. I would not worry about that stenosis, and I have often used Evol here, particularly because I'm comfortable with the radial force. And I think these are commonly seen in large cavernous aneurysms where you see a little bit of stenosis, which is pseudostenosis. You put a flow diverter in, and that just goes.
All right. So we carried on. This is, I think it's a pretty old case. I think maybe 6-7 years back. And bad access, we were doing through femoral that amount of time. And again, the same technique. You get a SIM, long sheath, implants in ECA, long sheath in, and then use a micro and 3A DAC to get a 5F Navian. In this case, we use a pipeline. As you said, we wanted a flow diverter with a strong radial force. I tried to do just want to see how much will it expand. So I think this is hyperglide balloon, and we tested it, and hyperglide or transform, and it was opening up a bit, but not too great. But we thought, okay, let's do the flow diverter, and we'll do another angioplasty after placing the device. And this is how, in this region, it just wouldn't open up. I used a lot of force, but this is what it would end up being. I could manipulate, resheath, replace. These are some of the videos. So again, we use a lot of force in trying to open up that area, try to do a flow diverter angioplasty of sorts.
This is pipelines?
This is pipeline, and the older pipeline, not even Vantage. So, and it just wouldn't. You can see how my guiding is moving. I was using a lot of force, and it just wouldn't open up. We tried our best. It opened a bit here, you can see, but still significant stenosis there, and we thought that's the best we can do. But we compressed the flow diverter a lot there, so that in angioplasty we are able to open it up. And again, you see there was significant narrowing for whatever we could do in the device in this region. We completed our deployment. This is how it was. Okay, and I did angioplasty. Okay, and this is how it remained. And is Matthew here?
No, he left.
Oh, so I called up Matthew. I sent him the pictures. I said, Matthew, what do you say? He says, it looks like a significant stenosis, Vipul, it may occlude, and patient didn't have collaterals. And so what to do now? Will we leave it here, or we do something more?
Coronary stent.
Yes.
Yeah.
Put a coronary stent.
So thankfully, Matthew was very clear. Vipul, you have no choice but go for coronary stent. We thought we'll give it one try, and we did a coronary balloon. It didn't work out. But navigating the coronary stent was a problem. So what we did, we took a microcatheter, placed a stiff coronary. Over that, we took a 3A DAC through the stent and then the guiding right up to that stenosis, because otherwise the stent wouldn't go in. When the guiding was there, then coronary stent, we could get it across. Otherwise, there was just too much friction. Yeah.
Yes.
And then we withdrew the guiding. That's it. The coronary stent was just stuck there. You can see it just wouldn't go any further. And we deployed it right there. And we left it right there. And then what happens in post-op? She was fine. And immediately what we see on table CT is a lot of enhancement in subarachnoid space.
So reperfusion syndrome. Hein?
Yeah. And look at her CT scan. After a few hours, we dropped the blood pressure and she developed seizures. Thankfully, no bleed. Brain was swollen on that side. Decongestion. We lowered the blood pressures. Thankfully, she did pretty well. No bleed developed. So she developed hyperperfusion syndrome there as well.
Is this hyperperfusion syndrome or this is contrast toxicity?
So see, this we have seen in many cases, dye in subarachnoid space, enhancing, and it goes away in few hours. But this, after a few hours, the whole brain was swollen on left side, sulci were gone, and this was hyperperfusion.
Oh, well, you haven't given contrast here. So the reason I'm saying is because you can get isolated syndrome because this is an isolated compartment.
Yeah.
You had so much contrast, that could be just contrast toxicity. And we have moved to Visipeg now because we had a lot of Omnipeg problem. And I think that is contrast toxicity on that side. That's why she has seizures and you must have given some steroids.
Oh, we always give anti-epileptics whenever we see such enhancement.
I think
We give anti-epileptics steroids
that
on the
is
table.
just,
Yeah.
but that is just immediately post procedure on table CT.
No, so this was, the seizures happened in evening.
Yeah, of course.
So we have seen, Tufel, this kind of enhancement, we've seen quite a few patients nowadays. Usually doesn't, you do the evening CT, is all gone. Most of it is gone. They do very well. We give steroids and antiepileptic. But this patient, we give steroids and antiepileptic, and she was fine post-extubation. But then evening, I don't have, this is from my previous institution, so I can't get more pictures, but the whole sulci were gone and the brain looks swollen. And in this case, we assume it's hyperperfusion.
What is true is that the contrast toxicity, most of the time the patient awake with a deficit. I don't know if the patient is awaking with the deficit, with the contrast toxicity.
Yes, of course. And
there is no time lapse of...
Yeah, that time lapse
And
that you're saying.
you have to understand that she was under general anesthesia, maybe low blood pressure, and the time she recovering the normal pressure, then she has the demand, then she has the reperfusion syndrome.
I think I agree, I accept that. If that is a timeline between, if you have a normal period, then you are probably looking at a delayed hyperperfusion. If you wake up with that, then you got to have a similar picture, then it could be contrast. You did I learned something here, what you are showing me is you had pre-dilated it.
Pre-dilated with a...
Which is amazing, because I wouldn't have done it.
Okay, that's very interesting. So, we use neuroballoon. Now, question is, would anybody pre-dilate with a coronary balloon?
So, I had this discussion with Rene about something very similar.
Yeah.
And one of the discussion was that we should, if you see stenosis, we should think it is real. And particularly here, after your inflation, it was real. Then you know that it wasn't pseudo-stenosis. Then maybe you should have just put a coronary stent in the beginning, because after the flow diverter, if you put in there and you knew that you're going to get occluded, you could have got into serious trouble getting through it.
I absolutely agree with you here. As a mind, we're not tuned to do coronary angioplasty pre-flow diverter, but what you're saying makes absolutely sense. It would have been so much more convenient to do it beforehand. And
yes, but the crossing, once you put a coronary stent, it's very hard to cross, okay? Sometimes you have big surprise. It looks straight, but it's very hard to cross. And if you have some manipulation to do for any reason in the stent to open it, I think if you do that, I would say, okay, you put a coronary stent, okay? You prevent the reperfusion syndrome by making pressure low for 3 weeks or 1 month. Then you wait for reendothelialization and then you go for flow diversion. Maybe it would be like that, because it's not an easy procedure, to...
Yeah, I know, and when I had to chat with him about this, and the problem is crossing the coronary stent, and in that case I put a flow diverter, and I kept the distal wire and access to get a coronary stent in.
I think the only way to get
which is exactly what he did.
After makes more sense for me.
Yes.
Because it's like silk going into a flow
Yes.
diverter. So even if it was a little bit challenging, you can go with the intermediate at the mouth of it, and you can always place a coronary stent.
I think this is a better way of going, because I think putting a coronary stent and then going through it, it's not easy.
To me also, it's you increase the difficulty of the...
Yeah, the key is to get your distal access catheter across the stenosis if need be, then coronary will navigate and withdraw your guiding catheter and then do it. Nowadays we are getting such terrific distal access catheter. This is an older case, and maybe that will make it more convenient. Yeah, Uday, please.
Yeah. So the point is, this is an extradural narrowing, whatever, maybe it's a part of the pathology. So you did it in the beginning, tried to open it with whatever balloon you had. But this is okay at this location. If the same thing happens, like for example in intradural VA, commonly seen, sometimes in M1s, then I would be extremely not keen to do a pre-plasty. We just deploy it, otherwise don't even do the case, because we have seen arteries rupture.
Yes, I absolutely agree. I have had some cases intracranial where I just didn't do the procedure if I think it wasn't going to open up rather than land up in trouble. I mean, so intracranial, as Uday raised, this is an MCA, there's a stenosis. What would we do? Would we not do the procedure, or you're okay with whatever we did here in cavernous location? This is just the last question. I think we are getting quite late. We go on. Next talk is Vincent Yo's, that's stent technique.
No, it's too fake.
Okay. All right.
Yes, you carry on. What do you ask?
Intracranial stenosis. Yes. Then these are safe to do in intracranial location with stenosis.
The same things? You mean like a supraclinoid aneurysm with a stenosis like that?
Kind of stenosis, would you be okay with deploying flow diverter and then trying to place a coronary to open it completely?
Yes, I think once you have done the job with the flow diverter, it looks okay to me. If you think the narrowing is too risky for the patient because you will have instant thrombosis, it is a crucial carotid, yes, I think it's not an obligation to make a 4 millimeter coronary stent. You can make a 3 millimeter coronary stent to ensure a minimum flow inside that, to not have occlusion.
All right, great. So we close this session.